Yeah, it seems that's kind of the trend for them types.
All right, we are going to get started. So welcome to the City Council Oversight Committee meeting of Thursday, February 8th, 2024. We have 2 items on our agenda today. We will start with item number 1, which is an emergency shelter update. So I'll recognize April Dozier.
Okay, so I understand now that you guys should in your email have the reports that I sent to the city attorney's office. And I'm just going to reference just this kind of one-page summary that takes information from some of the other attachments. So there's really not anything new and exciting to report for January of this year. Every month is about the same. We stay very full. We are at capacity every single night. Our splits are, about 70% men, 30% women. That's what we have capacity for, a larger men's space and women's space, but that's fairly reflective of the homeless community just at large. And then you can see a range of ages that trend a little bit older. That's something that you'll see if you spend any time at the shelter or even at Food and Shelter. Is just there's a great trend of older men and women in the homeless community right now. So just as some information about capacity and where we really need to be, I was at the shelter last night for the first few hours of open. And the way our shelter works is if you stayed there last night, you can get your bed today as long as you haven't caused any behavior problems and you get there by 6 o'clock. And at 6 o'clock, we had to turn away about 17 people. All of those but 5 were women. So that was like 12 women who couldn't get into Salvation Army and also could not get into a friend's house. And so, we definitely have a capacity issue for sure. And where those women went last night, I don't really know. I didn't, I also, Councilmember Holman requested last meeting that I bring a report for all of 2023, so that's also attached. You'll see that we had 441 unique people stay with us at least one day in 2023. I think that shows us some information that the homeless community is a little larger than what our PIT count normally will show, and the main reason for that is that a lot of people's homelessness is very situational. They divorce or a lost job or something really unique happens, and they find themselves homeless without a place to stay. They need a few days. They usually self-resolve using their own resources, whether it be family or personal resources, and then they get back into housing fairly quickly. It's the kind of long-termers that most of us are trying to figure out solutions for. So that's why that number is a little larger than what would normally be reflective on our point time counts.
Councilmember Holman?
Definitely appreciate you providing the yearly report like that. We talked about at the end of the year in 23 about the number of people that had found permanent housing that had stayed at the shelter at least one night since it opened in November of 22.
Yeah.
And who have been able to get out of that situation into permanent supportive housing or family or whatever it may be. And it's around 150 or so then. I assume we're getting close to 200 or so, I guess.
Yeah. So this number I included on here was 56 people that Food and Shelter paid money to help house. So we didn't do that for everybody. There were a lot of people, like I mentioned, that self-resolved through their own family resources. But yeah, in our first year, that report I think you're mentioning was a November to November report. So it was like our first full year open at a friend's house. It was well over 100 people that had came through the shelter and had found permanent housing, whether it was we put them on a bus and helped them get back to their parents' house, or they went to nursing care. We had a handful of people go to nursing care because they were seniors and really couldn't care for themselves. So it was a lot of different avenues out of homelessness, but that's what we're constantly looking at is what's best for this person.
150 or plus people that would have potentially continued to be homeless in Norman on our streets without this shelter option.
Yeah. Like there's really, you cannot underestimate a good night's sleep and what it can do for your decision making.
We talked about the number of veterans, people with disabilities is what percent currently would you say physical or mental disability folks that are having to stay at shelter?
So that's a tricky question because somebody with a mild form of depression technically has a disability. So we ask that question whenever they check in, and there's a report that's attached there that'll show you specific numbers, but it's easily half, if not more than half of. Did you say all my attachments are? Okay, so there's some other attachments that I just pulled out of HMIS that have some more specific data. But yeah, it's well more than half of our guests have some type of a disability. People that are, I would say, more chronic, have a more chronic disability is probably about a quarter of the people that, whether a pretty severe mental illness or a pretty significant physical disability.
And then, I think we mentioned before that about 25% of the guests that stay there do have jobs or an income of some kind.
Correct,
but
yeah.
aren't able to either find a place where they can afford it, or whatever various factors.
Right.
maybe.
Yeah, people on disability income, for the most part, the ones that we see are living on $900 a month. That's their whole cash benefit, and that, just isn't enough money to stably provide a place to live.
And there are still people that are working, getting up from the shelter, going to a job all day, and they come back and just have to stay there.
Yeah, we housed a man today who had been working for the last 6 weeks, has enough money to pay his own rent. All he needed was a little help from us, and we were able to do that for him. So, yeah, it's really providing an opportunity. And through all the controversy about it and some of the issues that have been connected with it, it's really providing an opportunity for people that they would not otherwise have.
And then was the part about, so 2 people were given bus tickets to return to where they came from. So we've talked about this before, that there is an existing program, or there's funding available or means available in Norman for folks that want to get back to wherever they may be from, where they may have family. We already do have the ability to help them do that.
Yeah, and it's just a food and shelter funded program. It's not like a continuum of care program or a grant funded program. It's money that we raise and that we budget for within our budget, because it's a rather inexpensive way to end somebody's homelessness, to get them to a place they have to live with a bus ticket, as opposed to keeping them here and sheltering them for a long period of time. So we're more than happy to do that.
We can't force them to do
Right.
that, right? We can't make them get on the bus
Right.
and go somewhere.
No, that would probably be against people's constitutional rights, but we do, one, if they request it or we encourage it, do you have a place you can go? We encourage that. But we also confirm with their family that they will have a place to live there, so that we know we're not shipping somebody to be homeless in another community.
Okay, thank you.
Councilmember Grant.
I was digging into the data. I had one note, I'll start with that. I found it surprising, 14A, history of domestic violence, sexual assault, dating violence, stalking, or human trafficking, as like 127 people that came through have a history.
That's just who self-report too.
Yeah. And then looking at, my head goes to, well, when was that, and does it have a correlation like with when they're experiencing homelessness? But so within the past 3 months, that's 26 folks who self-reported, and a year or more ago was like, surprised me more, but it was 56. So like pretty recent experiences. So yeah, just wanted to highlight that. And then my question around 13A1, physical and mental health conditions at the start, and then 13B1, physical and mental health conditions of leavers. I did see a dip in people when they were leaving with both alcohol use disorders, started at 30, and by the time they're leaving, it's down to 24. So it sounds like maybe some people are getting a handle on things.
And those are self-reporting things.
So they might not also.
So it could be that they're not answering their exit questions, or we didn't get to because if we answer no exit interview completed, it just automatically puts a null in those reports. So it's not an incredibly accurate assessment of that specific thing.
Do you see dips though? Are folks, I guess, starting to engage with services in a direction that's going to help them stay housed and not fall back into.
We see.
I mean, I guess people struggle, so.
Sure. We see a couple of things. One is people who get drunk all day don't get to stay in the shelter. So they make a decision. Am I going to stay around and hang out and act foolish, or am I going to make sure I have a bed to stay in at night? And we do see a lot of people edit their behaviors, edit their drinking and their drug use, because they know that's an avenue to make sure their bed is there at night. So we definitely are seeing some of those. And I can say that from things, staff reports, but also a lot of the folks that stay there I've known a very long time, and I'm like, never seen this guy sober this long, So like, it's just some of the knowledge of having known these folks for so long. But some of that is also, again, self-reporting. It's not that we drug test or anything like that.
Okay, that's it for me. Thank you.
Just about the domestic violence comment. So this is probably not new knowledge to you guys, but domestic violence is the number one reason women become homeless. So it's a very significant problem. These guys can tell you that.
Especially in this state.
In this state, even in this very wonderful community. And our women's shelter just can't keep up with the number of people that have to get away. So we are usually their second referral is when they present at the ER. If they can't get into Women's Resource Center, we're usually their second phone call.
Councilman Montoya?
So do you all track the individuals that stay there? And what I mean by that is, so if you have Sally who comes in, are you tracking her and her progress and like her plan to be housed or jobs or things like that?
So we have our case management staff is divided up into like a bed number that's their bed number caseload. So their job is like, okay, when women 1 through 10, I'm just going to make up something, like Jane is in charge of creating a case plan with those folks and then kind of staying in contact. Where are we next? Now, our goals are pretty simple with folks. We want to help them get their identification, which is ID, birth certificate, social security card. So we do, because those things are step one to get a housing application in. And then we follow up, can we now get your housing application submitted to the housing authority or to one of the housing providers here in Norman? So we follow up as far as that goes. But once they get really in the queue, there's not a lot we can do except just keep encouraging them.
And wait until
something comes open, which can be a frustrating thing for the guest and also for the service provider.
Okay, and so can you describe what supportive services are? I mean, I know there's food and shelter, so there's the meals. So just so that to kind of educate
Sure.
me and others listening on, because I mean, I keep hearing term services, I'm an accountant, so I live in the world of reading tax returns and organizational documents.
Yeah,
So
I hear you.
please help me understand the world in which you operate.
Yeah. So in our world, the term supportive services is everything that's not the bed they're sleeping in. So it's taking a human and assessing what their holistic needs are, from physical needs to mental needs to cognitive needs to medical needs. And then the supportive services are the individual services that meet those needs. So one of the reasons our continuum of care is called a continuum is because it's intended to be a circle of services wrapping around the individual that include safety needs, that include medical needs. So we partner with Norman Regional. When somebody has a medical need that needs to be met, we can get them into services that way. Food needs would be food and shelter, or even Salvation Army, who provides a food pantry and some meal services. Mental health services would be a supportive service, and our partners at Central Oklahoma Community Mental Health are the number one provider for those services. If somebody needs addiction treatment, so they need to get into even detox or even non-residential services, we use our partners at the Virtue Center. So it's really taking what an individual person's needs are, and every person, I mean, even every person who's homeless is unique, and what supportive services they need are separate, but it's kind of all spearheaded by one case manager who's like, okay, my job is to know this person intimately. not to use that word, but to know what's going on in their story and what those needs are, and then call my partners and say, I need you to come in and help with this and this, and then we all kind of wrap around. So that's what supportive services are,
Okay, okay.
if that makes sense, yeah.
And in my research, trying to understand, homelessness overall and just the nationwide crisis that we are experiencing and the ripple effect that's going to ultimately make it its way. So I saw that, HUD had issued a report called the Annual Homeless Assessment Report Part 1. And it contained links in it, which was interesting to PIT and HIC count numbers. So I guess that's housing inventory count, which is available beds.
Available beds, yeah.
And, it's by state. So it's real interesting to see all the different states and how things have changed. So, in that report, the link to Oklahoma, in 2022, the PIT count was, you probably know these numbers, but it's just surprising that 3,754 people in 2022 compared to 2023, 4,648. That's an increase of 13%.
It'll be higher
but
this year.
then the
Those
the
are
bed
state-
count.
Those are state numbers.
Yeah, state. Yeah, sorry, state.
for the record.
State of Oklahoma. So yes, just want to be clear. I
Increased 13%
selected the
statewide.
link, and then it has an Excel spreadsheet where you can filter. I mean, I use filters, so I just filtered down to Oklahoma. So these are just state of Oklahoma numbers. So then the bed count for the same time frame was 3,310 to 3,404. So that's just an increase of 3%. So you have this huge increase of homeless population of 13%, but then you only have an increase of 3% available overnight beds. So
Yeah, and I would tell you,
It's-
Norman made up most of those increase in beds by
Really?
by opening the shelter, yeah.
okay, so that was it's concerning that
Yeah.
that's what's happening,
Yeah.
and I guess that was also the nationwide number was 12%, I think.
Yeah,
over-
it's just, yeah, the
overall.
increase is really
Yeah,
everywhere.
and in my conversations with others in other communities that work with the homeless population, they talk about how they are seeing first-time homeless people because, mostly it's financial reasons, like, the price of housing and, just everything overall, food,
Cost of living,
just
gas,
basic cost of
everything, yeah.
living. And one of them had indicated, the greatest majority are these first-time homeless because they have to choose between, I can either fix my car so I can get to work, or I can pay my rent. And when you have to choose between that, so he said that he has seen about 200 additional compared to last year.
Yeah, that's a huge number for us too, of people staying at a friend's house or showing, like presenting to a friend's house and finding out there's no space and they get to sleep in their car at night because, first-time homeless, situationally, those just strange situations that happen.
Yeah. So what kind of patterns or what are you all seeing at a friend's house?
So we're seeing two things. One is, brand new people, brand new to homeless, have never been homeless before, and their situation is, I was sick for 3 weeks, and when you're an hourly employee, you do not get paid if you are sick. You just don't, so there's no compensation for you, and that really begins to snowball. So we're seeing a lot of those folks. We're seeing a lot of seniors, like older seniors and people in wheelchairs. You guys are probably seeing this too, a number of people on the street in wheelchairs. That's like something I haven't ever seen before in my time at Food and Shelter. And when we talk to those seniors and find out what's led to this, it's really, they've been priced out of their housing. Like I talked to a woman last week, she'd been in the same apartment for 13 years. And the landlord renewed the lease at $150 more per month. And on a disability income, like she could not sustain that. So she just kept getting further. And that didn't include that electric bill, and that didn't include, gas in the car and food to eat. Because a single senior citizen doesn't get a lot of food stamps. So it was, the budget just did not work, and she eventually was evicted. And we're seeing a lot of that for seniors.
Thank you.
Welcome.
I have some questions around some further conversations that we're having about other program types and just like certain things. So we're talking more and more about some like single room occupancy and trying to like build up our housing stock with that, because I think we don't really have any of that in Norman.
Yeah.
And specifically around permanent supportive housing, which is what you do at Food and Shelter with the cottages. So how many people that are staying currently at the shelter would benefit from permanent supportive housing as opposed to just needing to get into housing because of other circumstances?
So, I'm trying to think back to who was there last night.
Yeah.
So on any given day, it could be different. But so we have 52 people that stayed there last night. On the women's side, I could say there's easily a dozen of those women who really need permanent supportive housing to be successful. The rest of them just really need something affordable. They don't really need somebody to look in on them 3 times a week. They just need to be able to afford to live. But there's, so on the men's side, I would say it's probably about the same 20. So maybe about 50% of the people that stayed there last night really need permanent supportive housing.
And those are the people that need permanent supportive housing because of disability or that could be mental, that could be substance abuse, that could be like a lot of different things, right?
Yeah, we have a couple of people that just have intellectual disabilities that really have never been in the workforce their whole life and were cared for by parents who passed away, and now they're just out there kind of trying to figure stuff out as a person with disabilities, and there's just nothing for them. So they will really need somebody to be in their apartment or their house 2 or 3 times a week.
So outside of, how many beds do you have, I guess, in the cottages for that type
So
of?
beds are flexible because we have family units and,
Right.
and it depends on the size of the family.
guess
So we have
units.
32 cottages,
Okay.
plus we have a 16-unit apartment complex. And then our one HUD-funded project is a permanent supportive housing project. And those are scattered site units that we lease, and then we kind of sublease to the person that we choose for that project. So in total, we have about 70 units.
Okay, and we're still not able.
Very short on those.
Still very short with-
very short on what
yeah.
we need.
Okay, so definitely seeing that this is something that is a priority and is a need to help continue to address
Yeah.
homelessness. It's not just we're talking about a shelter, but other services
Yeah,
as
and
well.
it's really what's needed to address chronic homelessness. So homelessness is a broad spectrum. There's single moms, the domestic violent cases, senior citizens. They just need affordable housing. They need something they can afford on their income. And that's where the basic concept of affordable housing or Section 8-based housing comes in. But for the population that I think most of our community is thinking about and concerned about, that's really where permanent supportive housing comes in. A lot of those folks, you can put them in an apartment, they will not be successful without the wraparound services that come with permanent supportive housing.
And then a large part of the conversation around, a future location that will be, the permanent location for the shelter, we have a talk about transportation. So I'm wondering, what are the trends right now on the people that are staying at the shelter? Like, where are they going? Do they need transportation? You said some are working. Like, how are they getting to jobs? What is the importance of transportation for these individuals?
So at the location that we're at now, we're actually fairly lucky that transportation is not a huge barrier. One, because the rerouted bus lines have a bus stop right outside the shelter door, so people can get on that bus anytime they want to. But also, we have a partnership with Norman Caravans who pick people up in the morning and transport them to one of 2 day shelters. So, or 3, I guess, if you count the hub. So they'll go to the hub, which is the mental health center's day shelter, Food and Shelter, which is our location where meals are served, or Women's Sanctuary, which is specifically for women. So they'll take them to one of those 3 places in the morning shuttle route and then pick them up from there to bring them back to our shelter or Salvation Army in the afternoons. And that's kind of their primary transportation to and from shelter. But then once they get to day shelter, they can request a ride to work or to a job interview or to mental health center or one of their other various places. So, or the bus picking up where it does right now is really, really beneficial.
Okay, thanks. That's helpful. Councilmember Grant?
I was wondering about interim housing needs, like those who may not need permanent supportive housing, but definitely could use interim housing and not being in a shelter environment. Are some of those tiny homes also interim housing, or have they become kind of permanent supportive? Or?
So they really operate, closer to permanent supportive housing, or you can call them really anything you want to, but the plan is that they get in and they stay until they don't need to be there any longer. And that's the timeline of permanent supportive housing as well. Interim housing, which is like what used to be called transitional housing, was like a 1-year plan. You're going to get there, you're going to stay 1 year. At the end of 1 year, you're out no matter what. That's kind of how transitional housing works. I do think that could use some of that. It didn't come up in the home-based study, I think, because nationwide it's kind of going away. Okay. So people are looking more like at what our current model is in Norman, which is a low-barrier shelter that doesn't have a time limit. So people have a place they can stay with support services in place. They can stay until they don't need to be there any longer. And then the next step would be permanent housing, whether it's on their own without wraparound services or permanent supportive housing.
Okay. Well, I was going to say, because we're all talking about housing options, whether it's a permanent location for a shelter or permanent supportive housing. So we've had people contact us. I'm thinking of our church right now, but with land, that some of it's buildable, and they were thinking interim housing, but maybe they might be interested in a different type, if that is the trend.
Yeah, and I think in conversation, I think I know exactly who you're talking about, but I think there's a fear that permanent supportive housing says forever, and it's usually not. It's usually 3 or 4 years as opposed to a 1 year kind of thing. So I think they that permanent supportive housing could meet the needs. It's just a title,
Well, and for that property, I don't know what their long-term plans are, but that's why they had been leaning in that direction, because they were like, well, eventually we might use it.
And we don't want people to live here forever. We want to be a gap, but really permanent supportive housing isn't forever. It's just it's just the title.
And then I was going to say transportation to education. Do you have anybody that has those needs?
Like to a more Norman or something? We have a couple of people that are that stay in the cottages that are in school out there that we have had to work out transportation for. It's a challenge because it is kind of way out there. But I think those, if we were going to try to enroll more people in that, transportation would become definitely an issue.
Well, I heard that they had programs for low-income folks, and transportation really is just the missing part.
Yeah.
So,
yeah.
Okay, that's it for me. Thank you.
Did you have another question? Go ahead.
So, on a scale of 1 to 10, so there's the private sector and then the nonprofits that help with the homeless population.
Okay.
So on a scale of 1 to 10, based on what the needs are, the gaps of what's needed, so how many are actually helping out and fulfilling those gaps? Would you give it like 5 or 50%? And so there's like a gap of, we needed an additional 50% of private and nonprofits to step up and help us out, community partners, if you will. So I know it's a tough question to ask.
Tough question. Mainly, I probably would just need some clarification. So nonprofits are private. So there's private and then there's government. So in some worlds they call them government and then non-government like. So we're all private, all of us that are out here doing the work.
Whenever I think private, I'm thinking of like individuals, corporations, things
Got
like
it.
that. And so
Okay.
whenever I talk
So, like,
nonprofit, I'm
for-profit
talking,
versus nonprofit. Yeah.
religious nonprofit organizations,
Okay.
student shelter, Salvation Army, like all the organizations that work with the population, as well as the for-profit, if you will.
I think there are a lot of people who have a heart and a real desire to see this problem get addressed, and there's probably about 10 agencies really doing the work. And I think that should be more. I'm not saying anybody because there are agencies like the police department. They are huge partners to ours, but they're not service providers, you know? And there are lots of people in that meet that kind of definition, that they're at the table, they want this problem to be addressed for a wide range of reasons, but that's just not what they do. We need more case managers, whether it be case managers that go work for an agency already doing the work, or it's an agency that is formed and that's what they do. I'm I'm of the belief, old school enough, that you just, if you have a program that's working, fund it. You know, if you know Hope Community Services is doing really great work, and they do, fund them. You know, if you know Thunderbird Clubhouse is doing really great work, fund them. And instead of trying to create a new agency that's then just going to be competing for the same dollars, if that makes sense.
Yeah.
But we have amazing programs that do incredible work we're seeing results. I mean, the results are there. It's, you know, they're indisputable at all the different agencies that are doing it. We just have to build in the capacity, and the capacity is funding. Whether it be city of Norman, county, private people, you know, whatever.
Okay. Yeah, I was trying to get a overall understanding behind, because it's such a complex.
It really is, yeah.
Very complex challenge.
It is, yeah.
Thank you.
Councilmember Grant.
Yeah, I have the luxury of doing all this and running and door knocking, and I run into mental health workers and all sorts. One was working with I guess you would call it charity, and they were doing rent assistance, and so that was something I heard today that has like pretty much dried up for everyone. I think you were talking about that at one point. So speaking of just funding things, helping somebody with their rent so that they don't need a shelter would be amazing.
Yeah, prevention of homelessness is a far less expensive investment than waiting till somebody becomes home, especially if you get into families, because a family who's homeless in Norman, almost 100% is going to go to a motel room, which is, even for us, for our discounted level, is $500 a week, you know?
So she didn't seem very hopeful there was going to be more rent assistance coming. She did ask if the city had more ARPA funds to maybe contribute to that.
Magic
Question
ARPA.
mark. But I was wondering more about the county, and do you know if they plan to release any more funds for?
Nothing that's ever been communicated to me.
Okay.
Yeah.
All right. And I guess you would have like alerts on government funding if it was out there. So nothing, it's crickets.
Yeah, there's not a magic pool of money sitting there that we've just all ignored for a long time.
Yeah.
You know, and just about that, to give you a perspective. So all of our rent assistance funds start at HUD and come through the Department of Commerce, which is an Oklahoma agency. And for our entire county, we're back to pre-COVID amounts of money, and it's $200,000 a year. Period. And so I can tell you, we write checks once a week, which was yesterday for us at Food and Shelter, and we spent $8,000 in 1 week. So it just goes very fast, and that's to keep families from becoming homeless, so.
Councilmember Holman.
It would definitely seem if we had the available units, would be way cheaper to
Yeah,
pay $1,000 in rent a month than having to rent out a hotel for $500 a
it's
week.
$500 a week, yeah.
Yeah, that is hard to take in. So outside of a friend's house, just food and shelter for friends. From what I understand, the vast majority of your funding is private donations
Yeah.
from people in Norman and outside of Norman that
Yeah.
just happen to care about this issue.
Yeah, we had a few good years, like with all the COVID money that came in, that it was skewed a little bit, but we're about 85% private funded.
And the city of Norman's contribution, our outside services funding last year was $225,000, and that is divided up between
Yeah,
multiple. So
yeah,
I've always tried to let people know that our city contribution is less than it's a fraction of 1% of our city budget
Yeah.
that we contribute to all outside services. So I did have a question. I know you guys aren't here for this item, but when it comes to enforcing the law, is there a Norman Police Department policy that instructs you to give special treatment to anybody in Norman, any group of people if they break a law or an ordinance in the city of Norman? Does the department give special treatment to anybody?
No.
I appreciate that answer. And sorry for putting you on the spot about that. But, the chief
It's an easy
confirmed that
question,
same,
wasn't
but
Yeah.
the chief answered that same question a few months ago, but I just wanted to reaffirm it because we continue to hear that same thing weekly. In my experience, that's not the case either, and talking with you and other officers, that's not the case, but I appreciate you answering that question. Yeah, it's just, I think it just shows further the need of being able to get these affordable housing units online, or looking at things like these hotels if they come available, or OU Motel, which is for sale right now again. And, our big concern last year about approving that development project that came forward, which has since fallen through, was what happens to the 100 people that live there. And a lot of folks may not like OU Motel and think it's unsightly and maybe it causes problems, but to me, I see 100 people that they're living there because there's nowhere else that they'd be able to live. And so if it was demolished and they had nowhere else to go, they would just be...
They will become homeless.
Yeah,
They
so there's a lot of opportunities, I think, there, and I think we're on the right path with our project that we got forward, and some other opportunities that might be on the horizon with our ARPA money and stuff. So, but I think that amount of money that has to be spent on hotel rooms really underscores the need for those single occupancy, 2-bedroom units, which would just be save so much more resources that could go to other things that you need. So I appreciate that. Thank you, April.
Okay, well, thank you. We had a pretty robust discussion this month,
Good.
but thank you very much.
All right. Yeah.
Thank you.
We will move on to item number 2, which is a discussion regarding the request for proposals for the mobile crisis unit, and I will recognize Assistant City Attorney Anthony Parrington.
Thank you. All right. So, I think that we had discussed just a bit of clarification, a few different things. Last time we met, I think it's been several months, but I think an RFP was a potential option. I think there's a lot more room to operate in terms of mobile crisis than, maybe just requires an RFP. And that's kind of why I wanted to come back to you guys today. And instead of, there was a little bit of discussion regarding, mobile crisis and generally at the last meeting that this was discussed, but it wasn't particularly specific or focused to a certain solution. So I kind of took that general feedback, and then I've tried to at least funnel it into a few specific options on how the city can move forward as it, corresponds to mobile crisis.
Is this presentation somewhere? I did not see it anywhere.
So, and the reason is, part of that is I was hoping to get some statistics from Department of Mental Health. I was supposed to get them by today, but that did not happen.
Okay.
But no.
We can email it out.
Yeah, please do.
So for a little bit of background, September of 2020, Social Service Task Force, there was a final report recommending the expansion of, this is going to be a common acronym, Central Oklahoma Community Mental Health Center. They operate a mobile crisis unit. That task force, I think, was started by Mayor Clark, and one of their recommendations after they had met was to expand the mobile crisis unit hours operated by COCMHC. And that's kind of, I think, maybe where this could have started, or this was a part of that conversation. In fiscal year, I think 22, council appropriated approximately 1.3 million. That came from a few different sources, but there's 1.3 million allocated for creation of a mobile crisis unit program. Then we hit summer of 2022, and then we have the rollout in July of 22 of 988 in Oklahoma, and the feedback from council upon that, knowing that was, or before that, knowing that it was going to roll out, was that you guys wanted to wait and see how that rollout occurred, because that seemed to be like a potential solution that was happening on a larger scale. Then, after we kind of put the lid on mobile crisis for the time being, council had other, priorities they wanted to move forward, such as, exploring solutions to homeless transportation, and exploring transit solutions for that population. There was an RFP that was put out. There was no contract awarded as a part of that RFP. We did purchase vans, I think, eventually, at least intentionally, to be used for that purpose. I think the intent behind the vans that we currently have has changed a little bit throughout the years. And right now we have one van that is currently available that needs a use. And then November of 23, it was the oversight meeting where council discussed, exploring mobile crisis again in an increased capacity. And since then, I've been working on, again, bringing you guys some options on how to do that a little bit more specifically and getting your feedback as we move forward. So here's going to be a presentation overview, and part of the reason why it kind of took a little bit to get to this point is because I think the feedback you guys gave was mobile crisis. We really want to pursue this. The issue is, if you ask every person you meet what mobile crisis means to them, it's going to come up with a different thing, and which is why I'm giving you a couple alternatives, because I want to make sure that I don't want to move forward with something that wasn't what you intended. So I want to make sure that we're on a good foundation in any way we move forward. So I think the part that that I'd like to start off with is talking about mobile crisis in general and kind of what that means and how it's different depending on who you ask. I also want to talk about Oklahoma's current mobile crisis system, and then also Norman's current mobile crisis system, because there are provider networks and systems currently already in place, and that's important to have a foundational knowledge of. Then we're going to, I think, talk about a little bit more about potential solutions here of different types of mobile crisis models. There are many. Every city does it different, but there are 4 basic categories that I found that most of them operate under. And then finally, with all that knowledge, what kind of things can the city do to move forward in mobile crisis, and where's the potential to add value? So, in approaching this project, I utilized something that city staff learned back in 2020. We participated in a program, the Bloomberg Harvard City Leadership Initiative, that was really focused on how to tackle complex problems and making sure that the actual proposed solutions to problems fit the community need. And the main focus of that initiative is starting from understanding the actual problem that's being experienced in the community, and then basing your solution, tailoring it on that feedback, and not starting from a solution to a perceived or problem. And what you find is you want it to be able to match the actual experience that your community is experiencing. Part of, I think the first part, for me at least, because I had no background in mobile crisis, is initial reviewing the literature surrounding mobile crisis. There's been a lot of recent studies about mobile crisis units because they're become a lot more popular. They're still very limited. And then I also wanted to talk to the providers currently in the state. So I talked to 988, I talked to the Oklahoma Department of Mental Health and Substance Abuse, Central Oklahoma Community Mental Health, obviously our internal resources here at staff, and to kind of gauge what the current environment is and where the potential gaps are that we can move forward and we can possibly fill here in Norman. So, with that being said, let's talk about mobile crisis and what it kind of means, and specifically what it means in Oklahoma, right? Mobile crisis basically is the provision of crisis intervention services by a mental health professional, right, where the consumer is at that time, right? So it's not going to be at a mental health facility, it will be where that person's located. And this is a very simplified example of that. For example, that will be at someone's home, or that could be at school, or that could be, wherever that person happens to be contacted, in like a public place. Now you can get into all sorts of different definitions of what is a crisis, right? What constitutes a crisis for a mobile crisis unit. This is all from Oklahoma regulations regarding mobile crisis units from the Department of Mental Health. I'm not going to go that into detail in this presentation, but I can at least tell you, simply put, mobile crisis units are when a person's mental health needs cannot be met over the phone. And that's kind of the definition that I liked, and that was given by one of the people I spoke with from 988, who is now the Director of Crisis Services for Oklahoma. So I think that's really important, because when you think about 988, it is a hotline for people who are experiencing a mental health crisis. And I think the idea from a mobile crisis unit standpoint, where it currently stands as Oklahoma, is that if we were talking to someone who's experiencing a crisis and we can't help them while we're on the phone, the crisis is defined by the individual we're speaking to, right? I don't necessarily think that there's a very strict set of criteria needed for when that person needs mobile assistance. So I liked that, it's very defined by the person, by the caller, and, can those needs be met over the phone?
Councilmember Holden?
So on that note, I think what I had in mind, and maybe others I think too, about 988 was, a resident that, or a business owner or whatever sees someone in crisis on Main Street, for example, and they call 988 and 988 responds to address the situation. But what we're hearing back is, no, that person who called has got to try to go over to that person and approach them and put them on the phone. And that's highly impractical, I think. Like, nobody's going to do that, most likely. And so it, in that sense, isn't kind of meeting what I had hoped that it would be helpful for, was giving our residents and business owners another alternative than calling 911 and having to have the police go out to respond to something that may not necessarily require police response yet or at all. And so I think that's kind of been my frustration a little bit about 988, is that it isn't functioning that way that I was hoping or expecting it to, in that way with the phone.
Mm-hmm. And I think there's a reason for that too, right? It is a voluntary service that is being offered, right? When you think about, the authority of someone to act in that kind of situation, I think 988 is a service that needs to be requested, and the person they are serving is the person in crisis. If that person in crisis is not voluntarily entering into that service, there's not a whole lot they can do, right? So that, I think, is the disconnect, and that's the gap.
Well, that's kind of why we held off on going forward with mobile crisis response, because I think we were kind of under the impression that 988 is going to dispatch a unit of some kind that will go and respond to this stuff and help kind of alleviate some of the demand for the police department to be the only options.
And that is one of the stated goals of 988. But again, what you've described are situations in which that may not be possible. Mm-hmm. And I think that, one thing I think that came across in the 988 meetings I had was, it's not a welfare check hotline, right? It's more of a voluntary hotline. Now, they can dispatch to families who have loved ones who are experiencing mental health crisis. What I was told is that they're dispatched to the person who calls. So again, it's still a voluntary service. And it's not one that, you can necessarily even force on your loved one who is experiencing a crisis. Now, that team can still come out and they can still meet with the loved one, and they can still help maybe the family work through what that crisis means for their family and offer them resources. But again, what it does not address is maybe a situation where someone is, a third party calls of someone who's actively in a mental health crisis. And that is, I think, you've described perfectly one of the gaps that is still in existence. And so I'm going to come back to this a couple times during the course of the presentation, because it's important when we, I think, discuss options, keeping these goals in mind and which ones we want to prioritize. These are kind of the stated goals of generally of mobile crisis units. Obviously you have the short-term goals of stabilizing that person who's experiencing a crisis, connecting them with resources, and then also, I think this is the most important one, following up after the crisis and making sure that that person is connecting with resources and has the ability to follow through. And then you have the long-term goals, and these can differ, and I think these are the ones that may need to be prioritized by council and what their wishes are, right? But generally, you're talking about reducing unnecessary hospitalizations, reducing the amount of law enforcement contact and arrests that come out of a mental health crisis. And I think that, you could also reframe it as in, decreasing the amount of time spent by law enforcement on these type of calls as well. So hold that in your cap for now, because we'll come back to that later. This is going to, we also talk about budget. Again, I mentioned earlier there was appropriations that totaled about 1.3 million from a couple different sources. Since then, council has spent or appropriated approximately 92% of those funds for other uses, meaning that there's only, I think, about $119,000 remaining in that account. So that is important to consider. Again, that's not a barrier necessarily, but it just, I wanted to appraise you guys of, where that budget stands, because you did at one point appropriate it. And part of that was also purchase of the vans. That was about $300,000, but also you have shelter services were coming out of that account, which is also a huge need. So, but again, that account has been drained significantly. Okay. Current services here in Norman, and I think this is, to me, was some of the more surprising, at least for me as an individual, as I learned some of these services here in Norman. Again, we talked about 988 Mobile Crisis. Again, that's a statewide, nationwide program. But it's also explicitly tied to, the locations here in Norman, right? Because we operate, or we house the provider for mobile crisis for McLean and Cleveland County at COCMHC. So, and they were in existence well before 988. So, they connect the callers themselves to those mobile crisis units that serve their geographical area, right? And then they can respond, the mobile crisis unit, if necessary, will respond in person to that person if their needs cannot be met on the phone. Most of those calls are handled on the phone that do not require dispatch. And again, that is one of the stated goals, is to have stabilization at the earliest level. And a lot of that can be handled through the phone call itself. Now, I think there was maybe a misconception in the public. I think, I don't know if I saw it or if I heard it at a meeting, that, when you call 988, you're not talking to someone from Oklahoma. So this was an interesting fact I learned about 988. 911 is based on your physical location, right, where you get routed to. 988 is based on your area code. It is not based on physical location. That's meant to reduce the stigma for someone having to call into 988. If in the case that they don't want to be located, right? Or they're worried that, if they call in, someone's going to appear at their house when they might not want them to. So it's based on your area code. So if you have a main area code, but you live in Norman, let's say you're a student, you call 988, you might be connected to the main operator, right? For the state of Maine. But let's say you're a 405 area code and you call 988. If you need to talk to a mental health professional, you'll talk to a mental health professional here in Oklahoma, right? The dispatch center and the company that operates the dispatch center is operated, and they are based out of Arizona. They do not talk to Oklahoma callers. They are the point where if there is a call that is being handled out of, let's say it's the Oklahoma City call center, and they say, okay, this person needs a mobile crisis unit dispatched to their location, the Arizona team will dispatch whoever it needs to be dispatched to that location. So the dispatchers who do not take public calls are in Arizona. The actual mental health professionals who are talking to these people located in Oklahoma or have an Oklahoma area code, those mental health professionals are located in Oklahoma. So you are talking to someone in your area. Okay, and then like I said, most of those calls are resolved over the phone without the need for dispatch. We talked about it as on a mental health welfare check service. Again, I think that identifies part of the gap. And then this is, I think, the most interesting part for me, mobile crisis units and how they operate here in Norman. Prior to 988, Central Oklahoma Community Mental Health Center operated a mobile crisis unit. They had a number that you could call and they could dispatch to your location. And they are required to provide that service under state regulations because of the type of mental health facility that they are. They're, I can't remember the specific designation they are. It's like a community mental health center, I believe. So we have that currently in Oklahoma. We are also getting a second one of those in Norman, I should say. Red Rock, I think, also is going to open their own community health center. Or
CCBHC.
Thank you, CCBHC. And they, as that type of provider, have to provide a mobile crisis unit in their scope of services that they have to offer the community. So not only do we currently have one in existence, we will be getting a second one as soon as they are operational. So, they're staffed 24/7. However, because of staffing issues, I think that, in the later hours, they may be on call for most of that time. They are not limited to only 988 calls. They can take calls from the community directly by calling the specified number that goes directly to them and directly to their team. And like I said, they were operational prior to 988 rollout. Central Oklahoma COCMHC also operates the Children's Response Unit for that crisis. That's a separate team. As far as I know, I think they might be looking to merge the two teams, but and they also can provide, but it's specifically targeted to children. So there are actually two mental health or mobile crisis teams in Norman. And you also, let's say that you have a 988 call and maybe, COCMHC is busy. There's an Oklahoma team that's on standby who can come down to Norman and does respond to Norman on occasion if it's a 988 dispatch.
Councilmember Holman?
So Norman residents, businesses, they can call that, they can contact them directly.
That is a question that I've had. The first person I talked to was COCMHC. And I wish I had the frame of mind and the information I had to ask them that question, because I don't know, again, 988 and how they dispatch calls is probably going to be different maybe than how COCMHC dispatches calls. So I'm not for sure if COCMHC can dispatch calls to someone who does not voluntarily want to be involved in that service.
So it seems like a person in crisis has got to be the one that calls. It's hard to,
Mm-hmm. Yeah.
that might not be at the top forefront of their state of mind at that moment, is to call.
Exactly, right? And so I think at that point, then you're talking about a different type of call, maybe.
Is the police department able to ask for this service, or if a police officer responds to a call, observes this type of, or some type of crisis, is that officer able to ask for COCMHC to respond?
Yes, and they can do so in one of two ways. They can either, call the mobile crisis unit, or of course we have the iPads that connects to COCMHC directly as well.
So,
I think they may even be staffed by the same team.
that would require the police to be the first contact, though, that person would have.
Mhm.
Okay. And then, I know maybe it's changed, but 6 months, a year or so, I know some officers had kind of mentioned how difficulty using an iPad or trying to get someone who's in crisis to, one, the officer having to hold the iPad in front of them with two hands, and getting that person to, while sitting in the back of a police car, potentially talk to a person on a screen, and that being somewhat of a difficult situation for the police to be in.
Mhm. Yeah, I mean, and I'm sure it's better than nothing, but I don't think there's any replacement for a human being.
Yeah.
But yeah, so and I think that, you're also dealing with people who may not be cooperative. And, I think you're still running into that same barrier. Maybe that person does not voluntarily want or is able to accept services. So yeah, and if PD wants to weigh in on that, they're more than welcome to.
What would you like me? I mean, I'd
Oh,
be
you
happy
don't
to
have
weigh
to.
in on anything, but what you said is accurate. I
Yeah.
mean,
Yeah, I just wasn't sure if it'd been anything new as far as experience using that with the department, since it's been going on 2 years almost.
Real quick, I do think that our dispatch is equipped also to divert calls that they get into through 911. I think they can divert some of those to 988 without dispatching
Okay.
officers as well.
And so our officers are currently using the iPads and stuff? And,
Yes, we have them deployed, yes.
and would you say that feedback is similar? Has it improved as far as actually in the field officers being able to use it and feeling safe about it and it being effective?
I would say it's probably the feeling is probably the same as it was. They're difficult. They have a nuanced situation when we can use those. When we come across somebody who we can't take into custody, that normally we can take. If they meet criteria, we don't need the iPad or anything like that. We can take action right then. But getting people to be cooperative and stuff like that can be difficult.
Does every unit have one of those iPads, or is it
I don't know if
a per
we're
shift?
a little over 60 deployed right now, so there's
Okay.
over 20 per shift.
Okay. Appreciate that.
Okay, and now we kind of get into talking about, I mean, that'd be leading kind of right into, I think, the problems and, potential solutions and how we can address this stuff. I think it's important, and that's why I took so long to try to understand the problem as best I could, simply because I want to understand where the gaps are and how we can best meet them, right? So I think that how it needs to be thought of is, a police mental health collaboration, because what you're not going to get is a situation where police are never going to respond to a mental health call, right? I mean, that's pretty clear. But, how can my scope was how can we currently leverage what we have, what we need, right? And how can we make them kind of synergize and meet the gaps in the capacity that we have with what we already currently do, which is operate emergency services. So, mobile crisis models, you have 4 main models that most cities, have employed. I've tried to at least talk to a community that has dealt with one or, more than one in some instances of these models. At the very basic, most fundamental level, I think you have CIT programs, right, which is officer-only model. It's a crisis intervention team, that's what it stands for, where, specially trained officers will respond to calls for service that have a mental health component. And maybe that's a team, maybe you just have a lot of officers who are trained in that regard. A lot of police departments have now started training more of their officers on how to respond to these mental health related crisis situations. I think PD does a really good job in training up our force. I think that's, the first step. Then you kind of go up from there in terms of complexity and, level of service that you're offering. So then you can talk about on the opposite spectrum, you have kind of what COCMHC is right now, a behavioral health only team. And that would be a civilian team made up of mental health professionals. And, they respond to those mental health calls. Some cities, what they do is, recognizing this gap, if there are 911 calls that may not fit, 988, and how they function, maybe maybe some cities contract with, a provider like COCMHC who can respond to the calls that we receive, right? And maybe it's on people who may not really want voluntary services, or who may not otherwise be able to be connected with the mobile crisis team through 988. Then you have the response model, which is like a team, a mix of, a law enforcement officer and a mental health professional. A lot of, municipalities have adopted this model in particular. And I think most of the times it's like a plainclothes officer, a lot of times they utilize, different, maybe it's like kind of a van or something to that nature. Branding is going to be a little bit different for those units. How they engage a call may be a little bit different. But they do have at least one officer and then the mental health professionals. And then finally you have this is more least common, but it is an interesting model, the case management team. And this makeup varies. I talked to a community, St. Paul, Michigan. They have one of these. They actually don't respond to the crisis. So the crisis happens and they find out about it. It's a mix of a law enforcement officer and mental health professionals. And what they do is they get referrals. So let's say someone called 911, they experienced a crisis, they made contact with police or through some other entity. Then that gets referred to their team, and they're the ones who do the follow up and the case management on that person to make sure that they get connected with resources after the crisis has happened and after the situation has cooled. So. I'm not really going to talk about that one in particular because I don't necessarily think that that's super common, and I think that might be for cities who have a really robust, either maybe they already have like a co-response or a mobile crisis response team that can already respond to those calls on the front end, and this is just a supplemental service. But the first 3 are the ones I'm going to talk about specifically.
Councilmember Holman?
We have the first one. Our officers are being trained in CIT, and not every officer yet, but I think maybe maybe they all are, but a plan would be the whole department, I guess, or all the patrol officers for sure would have that training at some point, I would assume.
I think we have
It's around 25%, a little bit more. The national model, if you look at the Memphis people who put this all together, have moved towards saying if you have officers that are interested in doing this, who want to be engaged in this, those are the ones you should send. Sort of like if you have a guy who's interested in SWAT, he's going to be a
Sure.
SWAT guy. If you have a guy who's interested in mental health, they're going to have different skills and talents and things they want to pursue. So everything that I've read recently has been use those people who want to do this. They're going to excel at it.
So I definitely agree with that philosophy. I guess I would say, like, you know, any officer on the street could encounter that situation, right? So is it a couple officers on each shift have that training at least? Is that how it's
Far more than just a couple.
okay? And then the model I first saw was the San Antonio. It was the crisis cops thing, and they had a unmarked unit, and the guy wore like blue jeans and sneakers and a t-shirt that was untucked, and he still had his weapon on him, but he had it, you know, tucked in the back of his pants or whatever. And so he was just like a guy you'd see at the bar or something, and you strike up a conversation with. And so that was kind of their approach that caught my attention a few years ago when I started looking more into crisis response and how different cities or police departments were doing it. In that case, it was a law enforcement and civilian team. Like the crisis cops could respond, but then they could also call in a van with mental health professionals that would come in, and they'd both be on the scene, but they were really trying to keep uniformed officers out of the situation if possible. They talked about how even the most calm and professional and collected officer, maybe just their uniform or their gun belt or something could cause someone to go overboard, and so that was just one of the main examples I had seen in the country was the San Antonio one. They even did a TV show about that. Yeah.
So I don't know how many more slides you have to get to, but typically we have a hard stop at 5:30. Yeah, because of planning commission and like cycling through stuff. So I want to get to your recommendations. Unless you have a specific question about this, I would like to get to the recommendations so that we can have a conversation about like what models we're thinking
What
about.
about the behavioral health
Okay.
team? So in that model, I'm going to go to a real life example of a man having a psychotic break in downtown. That model could go respond to that and assess that that is what it is and take him, to mental health care to stabilize, or like an urgent recovery care clinic. I know that's on the horizon.
Potentially. It depends, and every call is going to be different, right? And I think that, it depends on what criteria you set with that provider, who's comfortable at what type of calls they're going to be able to provide or, respond to. You're also going to, internally want to, figure out what kind of risk you want to take, like what severity are you going to send a police officer out instead of, or maybe that's a co-response, you send a police officer and you dispatch that mental health team. But that is potentially how that could work out.
Okay, thank you.
Yeah. All right, so I'm going to talk a little bit about perceptions of consumers on each of these models, but that's from a study that was in April of this year, published, or April of last year, in the journal Psychiatric Services. That was, I think, after out of some research that was done in New York, and specifically, I think it was Columbia University. But anyway, so for a CIT program, this is the least preferred option by clients and their family members so far. And when you talk to people who've actually engaged with these types of models, I think Norman PD does provide a high level compared to other cities on CIT training to officers. But again, I think what it does lack specifically is it doesn't offer follow-up, right? And it doesn't offer clinical solutions for those individuals experiencing crises. The civilian-only model, there are pros and cons, right? Most preferred by clients and families, which is not surprising. About 50% said that they preferred that model. It can avoid unnecessary interaction with PD, although that being said, you might have situations where PD is still called out, or PD has to respond based on the severity of the call. It can decrease the number of calls fielded by PD, which could reduce call volume, making them more effective elsewhere. The response times of mobile crisis units can be much longer than experienced by that if police responded. This is specifically the regulations for the state and mobile crisis units in the state. They have a 1 hour response time for urban settings, 2 hours for rural. And that can be quite extensive, and that is the number one complaint about these types of teams is the response time to actually go out. It doesn't address the higher acuity calls, so violence, clear suicide risk, stuff like that. Maybe if there's been a crime committed, those types of calls may not be able to be serviced by that type of team. And it is also, I would say, is in some capacity currently provided in Norman by COCMHC. And again, you have the co-response model, not as unpopular as I thought it would have been. 25% of clients and 20% of their families, that was their first choice out of all the models. They can potentially, if you have this type of model, they can respond to a wider range of calls because there is a police officer present. Higher acuity calls, violent behavior if a crime has been committed, etc. I think one of the best aspects of this model is it actually embeds a mental health professional in, the police department, which one increases their, capacity to deal with these types of calls because you have, a mental health provider. You just kind of increase your operational effectiveness when you respond to these calls. I think it also increases your ability to collaborate with mental health professionals or mental health agencies in general. And theoretically, you will get faster response times because, again, that's assuming that you can fully staff your program. Okay, here's where we get to the meat, which is potential city action. There are two potential general types of options that I've identified, I think, moving forward is, we can leverage current services offered in Norman, right? Offering more intentional support and collaboration with current services operated, right? Like let's say that COCMHC has the capacity to respond to calls that maybe 988 can't dispatch, right? Maybe that's simply just, leaning on them more or intentionally, working with them to kind of, move in that direction. Or we can expand mobile crisis services as they exist currently to greater capacity with either a city program or a city contract, and we can do it that way, which will obviously require funding. So 3 options specifically. I did also want to address the van, which is option 1, right? And I think that this is the most least expensive, easiestly implemented. And it does utilize the van, right? So, utilizing the van and using that as a resources for someone who's currently operating a mobile crisis unit already. Option 2, contracting with a mobile crisis unit provider to provide those services. Maybe that's in response to 911 calls, maybe that's increased capacity to field calls from the public. And that could be either, a civilian or a co-response model. It's very flexible, option 2. It is the most expensive, however. And then finally you have option 3, which is, I think, developing better working partnerships with our current providers to maybe better leverage, that partnership to serve more people. And I think that, while that doesn't sound, like kind of sounds like what we're already doing, I think there are a lot of gaps that are currently not being met that could be met by option 3. So I wouldn't say that there's no impact there. Leasing the van to a mobile crisis unit operating in Norman. Keep in mind there's only one agency that currently operates in Norman. This is arguably the easiest solution because we have the van and we can retrofit a van, right? And we would work with that mobile crisis unit or whichever provider would be respond to this request. We could retrofit a van. It's collaborating on a spec sheet for the van to outfit it. And I think it would provide utility because COCMHC right now, they have a van, they just haven't had the money to retrofit it. And I think the reason why you might want to retrofit it, you touched on this, there is not an urgent recovery center in Norman currently, right? This could be a mobile urgent recovery center if you think about it. It could be, maybe you need a quiet, private place to stabilize someone who's experiencing a crisis. That could do that. The sedan that or the van that the state of Oklahoma offers might not really meet that need, but they do have transportation currently. So it's more of increasing the effectiveness of that transportation and how can they use that to help with the service they're providing. This is going to be a pretty low impact, probably, but it could increase their effectiveness, right? But it might not mean that you're getting more calls or you're more, you're same level of service in a way, but you might just be providing it that much better. Option 2, again, this is the most flexible. Contract with a mobile crisis provider to operate solely in Norman. An example of this would be an RFP, right? Proposals for mental health providers who can dispatch mobile crisis unit upon request from PD or 911 based on calls that we are getting, not 988. This is how Oklahoma City is currently doing, what they're currently doing. They've issued an RFP, they've gotten responses, now they're evaluating those responses. They have done that after significant public input on the front end, however. So, how Oklahoma City is operating it is those teams would be a civilian-only team. They would operate out of, I believe, the fire department. They would be dispatched to calls that have a mental health component, and that's they're kind of treated like mental health EMTs. Is how I understand it. The yearly cost would be very significant. Oklahoma City is in the process of reviewing. I did ask about what those may have costed in their proposals, but they're not public yet, so I did not get that number. But we're looking at, I think, looking at Eugene, Oregon, who's published their numbers for their budget, and other similar cities of our size. It's probably going to be a yearly operating expense of about $1 million, if not more. Again, that's going to depend on the level of service you're providing. That is a very, take that number with a grain of salt. And you also, I think this is why this could be, a very attractive option. You have a very broad ability to tailor it to your community, to the needs of the community, because you can specify, in the service you want offered, what kind of service it is, right? Is it like a mental health issue that you're currently seeing, or is it more of a substance abuse issue that's co-occurring? Do you want those types of professionals to, respond to these calls as well? You can tailor the types of professionals you want on the calls. You can target specific populations. You can, again, a lot of opportunity there. However, I think that, this also requires a lot of front-end work on understanding the needs and the gaps in the community currently, so you can tailor it to those needs. And again, Oklahoma City went through a very, very public process. I think that they, hired a consultant who used to be a part of the Obama administration. They had a lot of public committees. They talked to a lot of people in the community. They did a lot of, front-end work to understand that need in Oklahoma City. And this, I think, is probably the highest impact of all three options. And then option 3, strengthen your partnership with your current providers. Right now we have the ability to cooperate. Right now we could, try talking to, maybe COCMHC or another agency, and maybe they could respond to some of our mental health calls. We're already doing that. We just did a rollout of, like Major Shattuck said, routing some 911 calls to 988. Low number of calls likely, but still, that could be one less person that is unnecessarily being responded to. And it also, this does not duplicate services, right, which is a potential with option 2. Because I think that the more mobile crisis units you have, if there's overlap in those services, you can kind of run into the issue of, you may still be calling 911 for some sort of service, and then maybe it's being dispatched from there. But I think the problem that I've identified, the duplication of services, every single mental health facility is going through a really hard time with staffing. And so let's say you're staffing this separately from the mobile crisis unit that's already operating here, right? They're already at a disadvantage in terms of staffing because there's not enough to meet the need, but you're adding more positions. So this allows you to keep the number of positions you have maybe and leverage those and use them more effectively. So, and then this can kind of even be combined with option number 1. You can use the van, to help support that agency or a agency. But if not, and maybe that's not the best use for the van, maybe there are other uses for the van that we could, have available, like ADA. It's a ADA accessible transit opportunity because it has the lifts. Again, the original purpose for the vans, I believe, was a homeless transit solution to and from appointment locations. So, there are options there. You could use that van for other purposes. So, again, I think things you should consider are, what are the goals that you guys are wanting to meet? Again, we'll go back to that slide here in a second. Also, the expected volume of calls that you'll get, and we'll get into that in a second. But right now, I have not gotten a clear answer. This is one of the reasons why I waited to send out the PowerPoint. I haven't gotten a clear answer on how many calls are actually being dispatched in Norman from 988 right now and from Oklahoma Department of Mental Health. I have received numbers from 2 a month to maybe 15 a month. That is not a high volume, right, for a 24/7 operation. So, I mean, how much money are you willing to invest in a solution that may get 15 calls a month? That's a consideration. You also, the service gaps that are currently available. I think that, me, one person, and the amount of time that I've spent on this can't really adequately identify those gaps and how to meet them. There will have to be work put into that. Also, the types of calls you're wanting to request or address, which I'll get into a little later. So at this point, now that you kind of identified the options, I wanted to ask you guys for feedback on what kind of goals you wanted to be met by this type of program or this type of service. And here are some of the ones that, have been identified, but is there any that specifically you guys want met, or are there any that you're thinking of, like this is the need that needs to be met in Norman, and this is why we want mobile crisis?
Like I said before, my envisioning of it is that a Norman citizen, business owner, whoever who observes something could call a service, and it not have to, and the police not be the only option that a regular citizen has, is to call 911 and dispatch the police. For them to be able, like I said about, they call 988 and they say, hey, there's a person in this location that's having some sort of crisis, and then a crisis unit responds, checks it out. If they observe that it maybe does need police presence, then they would ask them to come. Something like that is what I have in mind. I mean, and from the options you put in, I'd probably have it as like 3, 1, and 2. Like, what can we do to work better with what we have? How can we use our vehicle to, I like the idea of retrofitting, just exactly like the picture you showed actually, and then considering whether we need to expand it from that with a dedicated service, given how much you said it might cost. That would probably be the third option, but it's kind of a mix of all three of those, I think, right now in Norman. So.
Yeah, I mean, I would tend to agree with you on the option 3, option 1, option 2. Given the cost and I think the extensive community conversation that Oklahoma City has had about what the needs are, because I don't think that we have done that fully here. I know we have not done that fully here. It's been something that people have been throwing around for a while, but it's clear that I think people don't know of the opportunity with COCMHC, and that like there's a definite opportunity for information and getting that out into the community and strengthening relationships, because I don't know what how PD is utilizing those potential relationships with COMHC, and so like I think that's a first step, and then seeing would an extra van, because I was thinking as you were talking that having an extra van, they might not even be able to staff it appropriately because of the lack of people in the mental health field. And I mean, like, no, I know nobody is, it's really hard to find therapists and counselors and people right now. I'm on the board of the Virtue Center, and we consistently have that issue. And it's really about who is paying more money and what are the benefits, and like it's like this shuffle constantly of people raising their benefits and their salaries and things, and then they move around based on those things. And I feel like this is also a lot of information to digest, and the first time that we're really having kind of an in-depth talk about what this could look like. I know that you're going to have some questions, and we're running up against some time, but I don't think that this conversation is over by any means, and I don't think we're gonna make a decision today, but like maybe prioritizing how we want to go about, like, yes, building relationships, seeing if the van will be helpful, if we can retrofit, do something, and then start having those community conversations about what this looks like, and is this something that we want to spend a significant amount of money on to, like you said, maybe reproduce a service that is already existing. So, Councilmember Grant.
Yeah, I was gonna say long-term goal. Let's just say option 3 with that being homeless transport. I guess I would want to know, like, on the preventative front end of that, how we could see that actually reduce maybe the calls that we, or situations we've encountered firsthand. Like, I'm thinking of the psychotic break person. He was a Griffin patient that was released, wandered downtown for a week, and ran out of meds, and that's why he was there. So if we were thinking about option 3 and the van going towards transport, and you're having to like work with your partners, does that look like Griffin actually calling whoever is doing transport for folks like that? I mean, I don't even know if that would help that situation if that man wasn't from Norman to begin with, you know?
Yeah, I mean, I think that, that brings up another question, in terms of like, if you use it for that purpose, could that help, the solution overall? Again, it's going to depend on the case, right? Or is that person who's operating the van going to be comfortable transporting the person in the state that they're in?
Right.
Right.
But I mean, if this person had been caught, and I'm also not caught, but transported to their place of residence before they, ran out of medication and been effectively homeless for a week, they were picked up at Griffin or even at the jail, having people got told by, our municipal court that, like, when people are released from Cleveland County Detention Center, sometimes they end up at on-cue and drinking inside. So I think about, like, what a transport option might do for somebody who doesn't need the temptation on the way back into town. So I was wondering, would you need to look into that more just for the transport option, if that
Yeah,
would get the effects?
And I think it'd be hard to nail down that was actually the cause of like an increase in mental health calls. But at the same time, I think that there are other reasons, why we might want to offer that service, regardless of the fact of how it interacts with mental health calls.
Right.
If that makes sense. So.
I just see some of them ending up as mental health calls.
Yeah, that's true.
Yeah. Okay, that's it.
Councilmember Montoya.
So in just an effort of time, I do agree with the prioritization of option 3, 1, and 2.
So another recommendation I have, I will, again, let's go to the next one, right? Is data collection, right? Because I feel like another thing that can inform this decision, which we don't have right now, is data about the types of calls we're currently receiving, right? How many of those could be referred to a civilian-only team, and how many of those are we experiencing a higher acuity where 911 is going to have to respond regardless, right? Because again, one kind of suggests a co-response model, the other suggests like a civilian-only response model. And how many would, a current working relationship or a better working relationship or a more formal working relationship with COMHC, how many of our calls could we divert to them right now, right, with no, change from the city? And I think that can really be important to drive the appropriate response, right? Because if we have 90% of calls where PD's still going to have to respond, right, again, that's a co-response model that's leaning towards. Whereas if it's just a civilian-only team that can respond to it, maybe that's currently available now through partnerships we already can cultivate, or maybe that we need to expand our service through contracting with the provider. And again, so these are kind of the next steps. If you guys are comfortable with that, option 3, again, I think reviewing policy procedure we have, talking, COMCHC, kind of collaborating on, maybe maybe it's an MOU, maybe it's something like that. How can we kind of be better there? We're currently already in talks with 988, I know, on how to, maybe do a warm transfer, right? How to make, that process much more better for the client. So that's already currently happening, but it can happen to a greater degree. And then option one, right? If you guys are comfortable with it, I don't know where you guys want to use the van. Maybe it's a different purpose. Maybe it's this purpose. We could also, draft an RFP or an agreement.
Yeah,
to
I think
retrofit
that,
van.
I think that first contacting CMHC and really understanding how we can be better partners and understanding the data and the calls and the types of service that is really needed. I think that's a first thing before we start to think about drafting an RFP, because if they don't need the utilization of it, or like what their needs are, or like how their system works, and getting more information about that. So right now I mean, this is me, but I think that like going with option 3, starting to have those conversations, building out what the next steps could be, and then maybe we're ready to do a number 1 option with an RFP and stuff a little later, depending on what the needs are. And then continuing into community conversations and things about building out a more robust program. Councilmember Holman?
Yeah, I was just going to add that as part of that conversation and potentially leading into option 1, I mean, I'd be very willing to consider us covering the cost of a retrofit of a van and like $1 a year lease, if that's what it takes. But if that would help get them in a position where they would be more interested or willing or able, whatever, to partner more with us on that.
Okay. Is that
That's
the direction
plenty.
that you?
Yeah.
Thank
So-
you for really digging in and providing us really like a large, robust data set, or like I guess information set of like where this stands, what's going on in the community, and providing some options for us to move forward. Because outside of us just talking about mobile crisis response, I don't know that we've really had a full in-depth discussion about what it is, where we can go, what are the models, and what are the options. So I really appreciate this, and I assume we'll come back with further discussions about
That's the intent.
what's happened.
Yes.
Or-
I did not want to present you with a solution today, just
Yeah.
because that requires some policy-making decisions on the front end. So, and that's what I got today. So thank you.
Perfect. Thank you so much. All right.
Thank you, Anthony.
If there are no other questions, this meeting is adjourned.